Hello, it's Dmitry again. Today this should be the last video I should be making for the Mehlman Medical Internal Medicine PDF. This one will be on biochemistry. Now, there is another section in the book. I talked about this before. Let me actually just go to it right now. Yes, the Internal Medicine Mixed Bullet Points on page 375. I probably will not be doing a video on that because it's kind of all over the place, and it makes less sense to me for me to do that compared to just, I don't know, reading it myself. And of course, you can access the PDF online for free, and you can read it for yourself if you want to as well. It's not the same sort of formatting and presentation as the rest of the textbook, and so I'm a little bit more hesitant about that. But maybe I'm wrong. Maybe I changed my mind. So regardless. Let's go back to biochemistry and begin the chapter. Phacochromatoses, neurocutaneous disorders. Neurofibromatosis type 1, NF1. NF1, autosomal dominant, chromosome 17. Neurofibromas, cafe au lait spots, hyperpigmented macules, axillary/groin freckling, Lisch nodules, iris hamartomas, pheochromocytoma, optic nerve glioma, oligodendroglioma, ependymoma. Neurofibromatosis type 2, NF2. NF2, autosomal dominant, chromosome 22. In kids, sometimes causes bilateral cataracts. Bilateral acoustic schwannomas plus meningioma in adults. Tuberous sclerosis, TSC. So TSC1/2 genes, autosomal dominant. Paraventricular nodules, tubers on MRI of head, seizures, adenoma, sebaceum, angiofibromas. Subungual fibromas, renal angiomyolipoma, cardiac rhabdomyoma, hypopigmented macules, Ashley spots, hyperpigmented variety lesions, Chagreen patches. That's a lot, okay. Von Hippel-Lindau, VHL, autosomal dominant, chromosome 3, cerebellar/retinal hemangioblastomas, bilateral renal cell carcinoma, pancreatic cysts. Mutation causes constitutive activation of hypoxia-inducible factor. Sturge-Weber, non-inherited somatic mosaicism of the GNAQ gene, or GNAQ, I guess maybe, GNAQ gene. Port wine stain, birthmark, nevus flammeus, may also present as a violaceous papules in temporal distribution. Leptomeningeal angioma, presenting as seizure, glaucoma. I always like saying the word flammeus, nevus flammeus. Nevus flammeus, I guess you could say. Glycogen storage diseases. Okay, let's talk about it. Disease and then high yield points. Type 1 von Gurk disease. Deficiency of glucose 6-phosphatase, G6PD. No, sorry, is that correct? Glucose 6-phosphatase, so that's G6P. No, I'm right. It's called G6PD. All right, am I mistaken? Let's see, glucose 6-phosphatase. Glucose 6-phosphatase. Is that called something? Is there a short form of that? They call it G6PAs. So G6PAs, you can call it that. What is von Gurk called anything else? Von Gurk disease is also called glycogen storage disease type 1. Okay. Any other names? I don't know. I'm not really seeing anything else. GSD1, just glycogen storage disease type 1. Okay. I'll have to keep that in mind. But so type 1 von Gurk disease, deficiency of glucose 6-phosphatase, lactic acidosis, hypoglycemia, jaundice, hepatosplenomegaly, super sick kid with glycogen storage disease. What about type 2? Pompe disease, I would imagine. POMPE. Deficiency of debranching alpha-1,4-glucosidase, aka lysosomal acid maltase, aka lysosomal acid maltase. Cardiomyopathy, hepatosplenomegaly. The answer for glycogen storage disease plus heart problem. Type 3, Cori disease, deficiency of the alpha-1,6-glucosidase debranching enzyme, no lactic acidosis in contrast to von Gurk disease, not so sick kid with glycogen storage disease. What about type 5? We skipped type 4 to type 5. Type 4 wasn't good enough for us. We went straight to type 5. McArdle disease, deficiency of myophosphorylase, glycogen muscle phosphorylase. Patient usually adolescent or adult. Severe cramping /rhabdo after intense exercise, but normal serum lactate. So serum lactate is normal, but you have severe cramping, and I would assume that's rhabdomyolysis after intense exercise. Maybe rhabdomyolysis. Let me look it up. You can't just say. Well, I mean, of course you can say it, but it's not. I don't think it's sensible to just say rhabdo and not specify what you're talking about. It has rhabdomyolysis, which is a dangerous breakdown of damaged muscle tissue that releases proteins into the blood and can cause kidney and liver failure. Sorry, can cause kidney failure. Okay, kidney failure. Does not sound fun. Anyway. But it has normal serum lactate for McArdle, which is distinct from von Gurk disease, which does not, which has lactic acidosis. So let's go on to collagen disorders. Let's talk about this. This is going to be some maybe relevant stuff. Let's talk about it. Type 1, found in bone, predominates in late wound healing, white in color, elevated tensile strength than type 3. Osteogenesis imperfecta leads to fractures at different stages of healing, often mistaken for child abuse. Blue sclera, too easy, often omitted from questions because, again, it's too easy. They don't, we can't just tell you what the answer is. We have to make it complicated for you to figure out based off of things that are not as distinguishing, In the real world, you'll see, this person has blue sclera. Clearly they have osteogenesis imperfecta. We can't have it be that easy. We have to make sure that you have to go work for the answer based on all the other kinds of symptoms. And you know what? In fairness, in life, a lot of the times you won't see all the symptoms, including some of the key symptoms potentially for certain diseases. And so there's a point to be made about not making it so easy for you, because sometimes there will be situations where it's kind of hard to say, And so as a doctor, you have to exercise reasonable judgment based off of cues that might not be as obvious. But it is a little bit annoying, you could say. Anyway, let's continue with type 1 of osteogenesis imperfecta. Conductive hearing loss, malformation of ossicles. If ruled out osteogenesis imperfecta plus child abuse, think osteopetrosis. So again, if we see something with that similar presentation, but we know it's not osteogenesis imperfecta, and we know it's not child abuse, start thinking about osteopetrosis. What about type 2? Type 2 collagen disorder, found in cartilage, intervertebral discs, and vitreous humor. Stickler syndrome, congenital hearing loss. What about type 3? Found in blood vessels, early wound healing, pink in color, decreased tensile strength compared to type 1. Ehlers-Danlos, vascular type, leading to hyperextensible skin/joints, easy bruising, aortic dissection/regurgitation, mitral valve prolapse, myxomatous degeneration, Circo-Willis-Berry saccular aneurysms. Does not sound fun. But type 4. Type 4, found in basement membranes of the kidney plus alveoli, also found in the lens, cornea, and the inner ear. Alport syndrome, XR, which is X-linked recessive, mutation in type 4 collagen, eye/ear problems in males with hematuria, Goodpasture syndrome, antibodies against type 4 collagen, males 20s or 40s with hemoptysis and plus hematuria, linear immunofluorescence pattern on biopsy. So what they're basically saying is that when I say type 1 through 4, I'm not referring to, even though I was thinking of this initially, but really these are different kinds of collagen. So this is disorders of type 1 collagen. So you have a type 1 collagen disorder, one of the most obvious being osteogenesis imperfecta, if not the only, right? I'm not quite sure if that's the only one or if there's more than one, but osteogenesis imperfecta is a type 1 collagen disorder. It's messing with the type 1 collagen. So let's go through one through 4. Let's talk about it. Type 1 collagen disorders, what can we think about? Osteogenesis imperfecta. Type 2 collagen disorders, what can we think about? Stickler syndrome. When we talk about type 3 collagen disorders, what can we think about? Ehlers-Danlos syndrome. When we talk about type 4 collagen disorders, what can we think about? Alport syndrome and Goodpasture syndrome. Okay. Lysosomal storage diseases. All are associated with cognitive/neurologic deficits. Autosomal recessive except for Fabry and Hunter, which are X-linked recessive. I think that's what they mean by XR. Disease, enzyme deficiency, build-up products, and high-yield points. So the I cell, the enzyme deficiency would be, I cell disease, enzyme deficiency, N-acetylglucosamine 1 phosphotransferase. Build-up of the product would be many lysosomal enzymes. What's the high-yield point? Cannot synthesize mannose-6-phosphate. At the Golgi, M6P needs to target lysosomal enzymes to the lysosomes. Instead, the lysosomal enzymes are secreted into cytosol plus serum. Coarse facial features. Coarse should be spelled with an A, not a U. I'm just saying. Okay. Facial features, joint contractures, hepatomegaly, recurrent ear infections. Gaucher's disease, looks like Gaucher, but Gaucher. Glucocerebrosidase deficiency leads to a buildup of what you can imagine would be a glucocerebroside. Okay. We would have avascular necrosis of the hip, crumpled tissue paper, that is a lipid-laden macrophages. They answer if they give you lysosomal storage disease plus bone problem. Tay-Sachs disease. You are going to have a hexaminidase A deficiency, leading to a buildup of GM2 ganglioside. You have a cherry red spot on macula related to blindness, no hepatosplenomegaly, and neurodegeneration. What about Niemann-Pick disease? You will have a deficiency of sphingomyelinase, leading to a buildup of sphingomyelin. So you will have a cherry red spot on macula related to blindness again. Yes, in this case, you will actually have hepatosplenomegaly, unlike Tay-Sachs. Niemann-Pick is a longer name than Tay-Sachs, and hepatosplenomegaly is a long word. Okay, sure. So Niemann-Pick is the one with the hepatosplenomegaly. You also have neurodegeneration as well. Metachromatic leukodystrophy. You will have an aerosulfatase A deficiency, leading to a buildup of cerebroside sulfate, leading to progressive neurologic decline. Krabbe's disease will cause a deficiency of galactocerebrosidase, which causes a buildup of galactocerebroside and picosine. This causes AKA globoid cell leukodystrophy, globoid cells, giant multinucleated cells, and neurodegeneration. Fabry's disease, X-linked recessive, I believe is what they mean, has an alpha galactosidase A deficiency, causing a buildup of ceramoside trihexoside. Now, you will have angiokeratoma, small red purple dots on the skin due to capillary dilation, and heart and or renal problems for Fabry's disease. What about Hunter's disease, which is X-linked recessive? Well, you have an iduronate sulfatase deficiency, which can cause a buildup of glycosaminoglycans. That is to say, things like dermatin plus heparin sulfates. In this case, you have gargoyle-like faces, stridor, aggressive behavior, no clouded corneas though. Hunters can see the X, therefore XR, and no clouded corneas. Hunters as in when you're using a scope, I guess. Hurler's disease, or I guess if you're looking at a target with an X on it, I suppose. Hurler's disease, alpha L, will have an alpha L, which is probably levo, alpha L iduronidase deficiency, leading to also likewise the buildup of things like glycosaminoglycans like dermatin plus heparin sulfates, just like the Hunter disease. However, Hurler's disease, gargoyle-like faces, sure, stridor aggressive behavior just like Hunter's, but in this case you will have clouded corneas, and it's more severe than Hunter's. So Hurler's is worse than Hunter's, and the most obvious, it's very similar, right? They have the same buildup of products of glycosaminoglycans. However, it's an alpha L iduronidase deficiency rather than iduronate sulfatase deficiency you see in Hunter's. It's not X-linked recessive. And in the case of Hurler's, one of the most obvious features that's present that doesn't exist in Hunter's is the fact that they have clouded corneas in Hurler's. Okay? So that is the end of the biochemistry section. is pretty short, not very long. I think it is the shortest chapter in the entire book, if I'm not mistaken. This isn't even okay. Now it just turned 15 minutes. It's not very long. So if you like that video, I mean, hopefully it was useful to you. This completes our textbook with the understanding that I'm not going to actually read the final, talking point, whatever stuff he has at the end. Let me just check it right now. Again, the mixed bullet points that he has at the end. Those are for like practice stuff, if I'm not mistaken. Like you can see the kind of the vignette, and then he says, "Okay, what is it? Oh, it's like this, blah 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 blah." I think it might be useful, so you might want to consider reading it. But regardless of that, hopefully this was useful to you. Have a great rest of your day. Thank you, and